Oh, there we go. Oh, there.
Good morning and welcome everyone to another Telehealth Today meeting. I am James Hongs, the founder of telehealthtoday.net. Today is Monday, October 7th, 2024. We are preparing for our launch on November 1st. Please check our website out over this next month, and it'll be doing some changes. A lot of exciting things going on. But as you all know, every Monday we have an extraordinary practitioner on, and today is no different. This gentleman has been in the telemedicine basically his whole business career, works on making telemedicine and telemedicine companies more efficient. And it's a pleasure to have you. So I have Dr. Erkan Hassan, PharmD FCCM. That's quite a title. It is a pleasure to have you. The stage is yours. Thank you for being here.
Thank you, James. Let me know when can you see the slide?
Yep.
Okay, great. So, hello everyone. I'm Erkan Hassan, and I want to spend the few minutes I have with you today talking about telehealth and is it really worth all the hassle and all the investment that we need to go into this. As a little bit of my background, I spent the first 19 years of my career as a clinician at the bedside, working for drug therapy management of ICU patients. Very active in the Society of Critical Care Medicine. I helped form the pharmacy and pharmacology section there. I'm the former chair of that section. And as James alluded, I'm the 12th PharmD to be inducted as a fellow into the American College of Critical Care Medicine. Starting in 2000, I joined VisiQ, which was the first tele-ICU system in the world, and it has now spread to a global phenomenon. We covered 500 hospitals, 700 ICUs, 7,000 adult ICU beds. We have between 250,000 and 300,000 patients go through one of our beds every year. I was director of clinical affairs, and I had two major responsibilities to develop and implement our clinical informatics strategy as a business, but also how do we improve the clinical efficiency of our remote clinicians taking care of 400, 500, 600 ICU patients simultaneously 24/7. Since 2018, I serve as an independent healthcare consultant. I focus on telemedicine and clinical transformation. A couple of other things about me. I have 2 patents on acute patient deterioration. I have 60 abstracts, 40 publications, peer-reviewed publications, 8 book chapters. I'm on the editorial board for Telehealth and Medicine Today journal, and I'm the managing partner for virtual care for Pronexus Advisors. And on the right, you see my 1962 Triumph TR3, which is what I work on in my spare time, which isn't much, but. So let's talk about, is telehealth really worth the investment? And telehealth has really emerged as a valuable tool with benefits improving patient outcomes. However, most CFOs view telemedicine as a loss leader or at best a neutral investment due to substantial cost investments in technology, low volumes of use of telehealth, and low variable and inconsistent reimbursements. We still don't really know what the full reimbursement scheme is going to look like with that. And there are very few examples of direct financial advantages to using telehealth. Since its inception, telehealth programs are not low-cost investments. And when looking at the inpatient ICU model, initial total costs ranged from $1 million to $6 million, with annual bed costs between $50,000 to $100,000 per bed of care for these ICU patients. There is data that demonstrates that with this service over time, you will get a decrease from ICU length of stay, which can be between 25 to 30%, as well as drop in variable costs of about 24 to 25%. These financial benefits are not seen immediately, not in the first quarter, probably not in the first year. It may take several years to see this positive ROI. So from a financial impact, there are three methods by which to report the financial impact of telehealth. One is to drive revenue growth by providing services to outside your healthcare organization, be it a private practice, a hospital, urgent care, set of urgent care clinics, whatever it may be, but to drive offering the services outside your system. The second is to decrease costs associated with direct patient care, like we already alluded to in terms of length of stay, readmissions, bed turnover, that type of thing. And then the third is really to look at quality life years saved, which is a more complicated long-term financial calculation of the impact of telehealth on these patients. But I'll spare you that this is not going to be a financial presentation. And when I started off with, is telehealth worth the investment, we need to look at not just financial, but resources, personnel, etc. So I'm not going to focus this as a financial presentation, but rather what I want to do is concentrate on what I consider the three major critical success factors to make sure telehealth is successful and therefore a valuable investment. The first will be new organizational model of care delivery. I think what we need to do, in my opinion, is we need to completely change the patient journey for telehealth, and we'll talk more about that. Clinical validation. A lot of the solutions and products currently available on the market have not been clinically validated, and that's an important consideration in terms of preventing clinicians from using the solution. And then third, I see a lot of companies that run into the perpetual pilot syndrome and cannot get out of their way of pilot after pilot after pilot and never have a successful launch. So we're going to address these three. So the new organizational care model, I think, is telehealth is here to stay. And most healthcare organizations need to either develop or update their telehealth strategy. A lot of the organizations I deal with either do not have a telehealth strategy, they have a telehealth strategy but are not implementing it, or their telehealth strategy is so outdated that it's basically useless at this point in time. And it gets us back to the whole people, process, technology triad that people have talked about and we've heard about for decades now. One of the problems here is that IT projects are really typically difficult to manage. Most are not completed on time or on budget. And I think what I typically see, and think about how you implement this, but a lot of these projects are implemented in reverse. And they're implemented not people, process, technology, but technology, process, people. And because of this, people are the last area of the triad to be addressed and or totally ignored. And what I submit to you is that the people aspect of this is the most important part of the triad. And success in your telehealth model is less about the technology and more about how it is used, how it is integrated into care delivery, and how we integrate it with other enterprise systems. And so what I submit is the patient journey needs to change. Think about this. Currently in today's environment, you need to order a refill, you get on your app, you get the pharmacy app, you order a refill, you get off the app. You want to make an appointment with your PCP, you get on the app, you make an appointment, you get off the app. You want to see your PCP, you get on the app, or a specialist, you get on the app, you make the visit, you get off your app. Where I think we need to go in the future with this is we need to change the whole healthcare delivery model where you go into one system and you can take care of all your needs within one system. So the new care delivery model needs to integrate telemedicine into all aspects of care delivery. It's not just, I need now patient telehealth model, but because telehealth is here to stay, it needs to be integrated into the woven fabric of complete healthcare delivery, starting with the ED triage visit. Do I need an ED visit? 70% of the time, 40 to 70% of the time, ED visits are not necessary, helping with that. So the telehealth care model needs to fit seamlessly into workflows without delays, with continuous access to the team. How do we do that? Well, we need to, on the left column, these are the considerations, I think, for your telehealth strategy. We need continuous physiologic monitoring. We need cloud-based real-time data and analytics and predictive modeling. We need early disease exacerbation detection. We need to find patients early on as they acutely deteriorate before they've fully manifested themselves. We need timely, individualized interventions. We need remote monitoring patient engagement. So we need to take advantage of the RPM, but also get patient engagement in there, make sure we have good decision support tools and stakeholder collaboration. Notice at no point did I say AI or machine learning. That's a whole other can of worms that we need to address. But these are, on the left-hand column, are the things we need to consider in the development of our telehealth strategy in the fabric of all healthcare delivery. And then we need to look at these other three columns in terms of how do we integrate this in patients with chronic disease. Most patients in the US have one chronic, 40% of patients have two chronic diseases. Chronic diseases are a leading cause of death and disability in the US. Our current healthcare system is intermittent episodic care for these chronic diseases. That's very inefficient. And so the question becomes, how do we incorporate virtual visits as supplements to, not replacements of, face-to-face visits? So a lot of times people consider one or the other. We need to develop models where they are synergistic and are supplemental to, not in replacement of. And then with chronic disease, we need to consider management of the chronic disease itself, acute exacerbation of the chronic disease, but then a new disease state on top of the chronic disease. All of those things need to be factored in how you manage these patients. Disparities in healthcare, and we need to provide service to populations with limited resources. When we say this, we typically think of rural settings where there's care that without broadband, without the healthcare delivery system fully integrated, these healthcare deserts. But what I submit to you, it's not limited to just these rural areas. There are areas without transportation or childcare in urban centers that we need to focus on and optimize telehealth to meet these needs. And in urban areas, there's a huge shortage of primary care providers. So really, primary care providers is a healthcare desert in urban areas, not just rural areas. But rural areas are obviously a huge problem. I've spoken to people in Australia where they need to figure out how to provide care in the outback in Australia. And there, when they talk about transporting patients, it's not an ambulance, it's an airplane to transport these patients to rural urban areas. And that can have costs up to $30,000 per transfer. And then specialty care. How do we leverage, we see all the different teleneurology, telecardiology. I spoke with someone who's doing teledentistry in the ED. But how do we provide quicker, more efficient care? 40% of initial problems in the ED can be resolved via telemedicine and can avoid the ED clutter. Quicken face-to-face appointments, and obviously there is fewer missed work days by patients and travel considerations. So all of these need to be factored in our telehealth strategy as we develop that. And again, what I suggest is if you have not updated your telehealth strategy, it's probably out of date and you need to revisit it. Let's talk about clinical validation. What you see on the top right graph are the number of publications. This was published in 2021. And these are the number of publications per year in PubMed. And you see, obviously, between about 2010 to 2019, an exponential growth in the number of publications on telemedicine models, predictive models. But the pink at the very tip are the number of published studies that mention external validation. So we've all seen, I've seen, RPM solutions out there that say we decrease ED visits, we decrease readmissions, we decrease costs. Very few have clinical validation that they actually do what they say they're going to do. And that's very important because to gain clinician support and acceptance, you need to prove that your widget actually does what you say it does. On the bottom left is a study that was done in 2023 in JAMA. And what they looked at is they looked at across 10 countries, and you see the countries listed on the bottom of each bar graph there. And they looked solely at upper arm blood pressure cuffs that were sold and available in these 10 different countries. And what you see is the percentage by country of those cuffs that were sold to patients that are not clinically validated. So, for example, in Australia, 95% of the cuffs sold were not clinically validated. Overall, if you go across to the far right, the total is about 80% of, in these 10 major countries, the upper arm blood pressure cuffs that people are using, have bought and potentially using, that have not been clinically validated. My question to you becomes, what happens when we are making clinical decisions of what to do patients with their blood pressure readings when these devices have not been clinically validated that they're reliable? Is it worth the investment? So we need to do clinical validation so that clinicians are assured that the solution actually delivers the promised outcome. And clinical validation needs to do two things. It needs to address reproducibility and generalizability. So reproducibility is the validity of the device, and generalizability is the transportability of the device. In other words, is it reliable in different patient populations as we move from population to population? So is it valid in the population we're using it, and is it transportable to different populations? Models that have looked at this, and about a year or two ago, Epic really ran into big trouble with their sepsis screening model, where it came up with a very high predictability, but once they transported it to other settings, it had very poor predictability. So they usually perform poorer as you go to external environments and go from one environment to another and different populations. And again, clinical decisions on non-reproducible models could result in poor patient outcomes. So what are the do's and don'ts of clinical variability? For clinical validation, what are the do's and don'ts of clinical validation? You need to have a formal written plan. You need to use an external site from where you developed your algorithm or your solution. And my approach is to go in and say, hey, we want to partner with you to help clinically validate this. And it needs to be used at the moment of clinical decision making. That's where you want your real assessment. What clinical validation is not to do another randomized controlled trial for 2 years, that lasts 2 years of 10,000 patients. That's not the idea. A randomized controlled trial is to generate new research, new data. what you're trying to do with clinical validation is really drive the improvement process of quality improvement processes with clinical validation to show that the solution actually does what you suggest it does. The let us try it out in some patients is not a validation plan. And I've seen many places where a healthcare innovator has a solution, will go to a health system or providers, and they say, you know what, let us try it in 100 patients, 200 patients, and we'll give you feedback on that. I strongly recommend against that. That is not a clinical validation tool. A utilization project is not suitable for that need. So basic do's and don'ts of clinical validation. So let's move on to the last area of perpetual pilot syndrome. How can pilots are helpful, they are useful, and they will do a number of things. For example, they will develop a client partnership and trust between the innovator and the client site. The innovator of the solution will learn something that has not been known by hopefully learn something that has not been known by the pilot. And really, it's answering the question of, does my solution deliver the touted outcome that I'm proposing that it does? That's really the question of the pilot. And we need to determine the effectiveness of the solution prior to widespread implementation of the solution across various populations, geographic areas, and patients. Again, it is not a large, drawn-out, randomized controlled trial. So there are several outcomes of a pilot. One, the pilot does not succeed. What happens if what should we think about if the pilot does not succeed? Well, the first question is, are we doing a pilot for the wrong purpose? The pilots are not a substitute for product design. They should not be used for product design. Was there lack of an appropriate plan? Again, the let us try it for a while is not a pilot. That is an inappropriate plan. What an appropriate pilot should do is define the goal, the roles and responsibilities of everyone touching the solution and the patient, and develop specific workflows. Specific metrics need to be clearly established to define whether the solution works or it doesn't work. The other consideration is that the solution does not actually solve the intended problem. So it doesn't do what you intended it to do. There's a disconnect between the solution that was developed and the end stage user's clinical expectations. The other issue is if the pilot only focused on low-hanging fruit, it has basically avoided the tough questions. It's answered the easy questions, but it really has avoided the tough questions. And the final consideration is that the pilot was inadequately resourced, either in terms of people, capital, commitment, or data collection. So those are all the reasons that the pilot could be not successful. The other issue is the pilot was successful, but it did not lead to clinical adoption of the solution. And there are basically three big areas to consider when that happens. The first is the pilot was successful, but it did not change behaviors. Why did it not change behavior? If the pilot concluded before the new behavior became a clinical habit, reverting to the old clinical habits will reappear. This is especially true if the pilot was conducted during a slow period of work. In other words, if you're looking at trying to avoid flu exacerbations and emissions from the flu or community-acquired pneumonia, looking in the summer times is the slow period. The winter time is the peak period for that. So if you did the pilot during the slow period in the summer months, the old habits will reappear during the hectic times of the winter months. Number two, success metrics were not clearly established and documented up front. These need to be clearly defined, not just clinical metrics, but financial metrics, operational metrics, staff satisfaction metrics, provider satisfaction metrics. All of those need to be addressed up front. And then the final is what I call perpetual pilot syndrome. This is where you end up doing one pilot after a successful one, and you just keep doing one pilot after the other after the other. This can actually inhibit growth and use of the solution. This also occurs when pilots are allowed to drag on too long. And I think one of the problems and the etiologies of perpetual pilot syndrome is the lack of initial clarity as to what happens after the pilot. Remember, very early on, the very first block up under number 1 is that we have that client partnership and trust. And that's where the conversation has to occur as to what happens after the pilot. So how do we avoid perpetual pilot syndrome? The way we avoid it is we have to keep the goal in mind. And there are two different goals. One is for the client goal, the healthcare provider system goal, which is to get firsthand validation that the solution works in their environment and in their population. The second goal is the business goal of gaining commitment for broad deployment when the clinical and financial outcomes occur. So we have to keep the goal in mind. There are two different goals and we have to offset those. We have to avoid open-ended pilots. Most of the pilots I work on and do data collection, it takes a while to start data collection, but once we get to data collection, in my opinion, there's no reason you cannot be in and out of a pilot in 90 days. There's no reason you cannot answer the question of, does my solution solve the problem I'm trying to solve with data collection at 90 days? And then avoid perpetual pilots by partnering with the client to agree to additional deployment. And you can do this in phases. It doesn't need to be day one pilot site, day 2, all the other sites, but clearly establish milestones per each phase up front and expand to the next phase only once the agreed upon milestones are met. But then also you need to agree on the process if the program is not successful. And if the pilot has not been successful, we agree up front as to what to do about that. Clinical adoption of new solutions, you need to be aware that in terms of healthcare, there is a huge lag time for adoption. And depending on who you read, it's somewhere between 17 to 23 years of adoption. And here's some examples. In 1747, we knew, well, the British knew, Captain Cook knew, that citrus fruit was shown to prevent scurvy in ships. However, it wasn't until 1867, 120 years later, that British law mandated citrus on ships. 1968, we developed the flu vaccine. As of 2024, less than 50% of the US population has a vaccination rate. That's 56 years. 1977, we got the pneumococcal vaccine. As of 2022, 24% vaccination rate with the flu vaccine. That's 45 years. 1987, we developed lovastatin. Great. The statins, wonderful drugs. As of 2018, 27.8% of patients with an indication for a statin are actually receiving one. 31 years. And in 1993, the recommendation was made that diabetics should have foot exams annually. As of 2020, 15% of diabetics are compliant, or we are compliant with annual foot exams in only 15.6% of patients with that 27 years, and we're still there. So it takes a long time for clinical adoption. One of the problems is most healthcare businesses fail in the first 5 years. So how do we ever reach that 17-year mark? So I'm going to conclude with, there's no question the evolution of telehealth has been rapid and wonderful over the past decade. It's not without challenges. I do think there are examples where the benefits of telehealth are improved patient outcomes, enhanced patient engagement, reduce hospital admissions, increase accessibility to care, and it is cost effective in my opinion. The challenges are technical issues and difficulties with those technical issues, health literacy on the public side, not just the patient, but provider as well. Patient privacy and security, patient confidentiality is still a very big concern these days. And then integration into existing systems is a problem and a challenge for us in telehealth. And with that, I will stop there and turn it back to James and see where you want to go from there.
I appreciate it. That was very good. A lot different than we normally get. I thank you for it. And insightful. All right, so I do have some questions for you. And the first one, I almost interrupted you in the beginning and I didn't do it. But what is your definition of telehealth?
Wow, that's a good one. That's a good one. Okay. And I actually have a slide that I've developed over, and it constantly keeps changing because we've got virtual care, we've got digital health, we've got e-health, we got mobile health, telehealth to me, and then under telehealth we've got telemedicine, telehealth, RPM, wearables, sensors, asynchronous, synchronous. To me, telehealth involves all of that. To me, telehealth means not just telemedicine, which is the provision of clinical care, but also telehealth to me involves using automation and technology to do things like setting appointments and those types of things and filling out forms, getting informed consent, that type of stuff. So it's both the clinic, to me, telehealth is using the technology to do both care delivery, but also the paperwork of healthcare.
Okay, so you're counting CRMs and record, everything is all encompassed by telehealth.
I think so, yeah.
That's good. That's good. All right, so now here's a little question on your presentation and as a personal to like my platform and telehealthtoday.net. So you touch on forming, a telemedicine plan. So I guess my question is, for a practitioner on this website could be part of that plan. How would you tell them to do their due diligence or to make it happen or to implement it the correct way? And then also from the perspective of like a business owner like myself, how does it vary from, having multiple people using my service, whereas my practitioner is only using it in one aspect? What do you see some of the differences there and some of the similarities?
First, I think one size does not fit all, right? And during the pandemic, one of the most common questions I got from practitioners was, just tell me what system to buy. And my response to that is completely the wrong question you should be asking me. The question you should be asking me is, help me quickly develop a telehealth strategy. And so a telehealth strategy starts with, what problem are you trying to solve? Are you trying to solve, you want to be a market differentiator? Are you trying to solve, you want to leverage your limited resources? Is the problem that you want to improve clinical outcome in decrease cost? What problem are you trying to solve? And for example, if you're a rural health center and you need to figure out how to expand care in a rural area or your critical access hospital, and how to get more patients to your service provider. That's different than if if you have a big ED problem and a big wait time in your ED and you're trying to resolve that. So the question really becomes, what problem are you trying to solve as a provider? And then develop the healthcare strategy. Do your assessment as to what do you have on hand now? What's your gap analysis? What's the best way to address the solution? And do you build or buy? Right? I'm in discussions currently with a home healthcare agency. One of their needs is the home healthcare nurse, as they visit the patients at home. These nurses end up in situations where they have a clinical question. So how can we use automation to effectively answer their question while they're right there in the home, and avoid a follow-up visit and leverage that? That's a completely different problem than I want to improve the quality of, let's talk about tele-ICU, telecritical care, of improving quality of care delivery when I don't have an intensivist in my ICU. Does that answer your question, James?
Yeah. I think so. This is basically like, know who you are, know the marketing, know what you're trying to achieve, and then diagnose how the telemedicine can get you to where you want to go quicker or more efficient.
It's still the gap analysis to figure out where you are, where you need to be, and then do you build or buy the solution? And it really gets to, what is your priority? Is it mitigating resource limitations? Is it decreasing cost? Is it improving care quality? Is it accelerating innovation? Is it driving efficiency? What is the priority?
That's good. That's good. I had one more question I wanted to ask you about. You had talked about on one of your slides that the kind of let me try it on 200 patients is the wrong way to go about things. Can you give an example of maybe a better way to do that?
So the let us try it out scenario, that's what you're talking about, right? I think that's a wrong way to do a pilot. And I think a healthcare innovator that has a new solution, first off, when you go talk to a doc, the first two questions you're going to get is, show me the data and who's using it. Those are the first two questions. A lot of times, like I said, these solutions, they don't have the clinical validation. So as soon as you say you don't have any data, whoever you're talking to is going to stop listening. So you need to have that clinical validation. And I've dealt with CEOs of healthcare innovators that go to health systems and have a solution, and the docs there say, you know what, let us try it in 100 patients, 200 patients, and we'll give you feedback on your solution. I think that's a mistake for the main reason is there's no organized structure of how you evaluate this. And people remember the disasters. So if the first couple of times if I say to you, James, you have a solution, I say to you, let me try it in 100 patients. You say, okay, here, we'll give you 100 widgets, try it. And the first two patients are awful. Those are the ones I'm going to remember. And in the other 98 might be perfect, but the first two are the ones I remember. Compare that to, we now have an organized structure. We have an organized workflow of, this is what we're going to do when, these are the patients we're going to use it in, this is how we're going to use it, this is who's responsible for every aspect of it. These are the metrics we're going to pull, clinical, financial, operational, satisfaction metrics. And for each metric, this is success or failure. Now, I've got my 100 patients, 200 patients. I apply my metrics to them. Is it going to work in everybody? No, it's not. But you're looking at the cohesive group as opposed to one or two bad examples that are going to show up anyway.
That's good.
Does that make sense?
Yeah. You're defining the test with the validation. I love it. Yeah, because it has to be monitorable to a stance. But that goes with everything that you're saying of, I get you to clinical validation, and this is how, because I define each step and we put it as a process in writing so it can be shared and duplicated with others. Yeah,
Right.
that's awesome. That's good.
And now you have a protocol. When you go to the next site, you have a starting protocol. Yes, each site will be a little different and you'll probably tweak it a little bit. But from my perspective, I don't tweak the major parts of it. I tweak the nuances that each site is unique for. They may do one thing slightly different than another, but the main backbone still stays intact. So now I can compare apples to apples from site to site.
Yeah, yeah, yeah. That makes sense. Yeah. Sounds like you're very organized, and a lot of what you do is in helping other people organize their work and studies. That's good. Yeah, no, I commend you for it. Well, I think that's about all the questions I had. Is there a last statement or last set of words that you wanna leave these clients with? And maybe, especially for newcomers, somebody that's just getting into this, that wants to start building a private practice, if they were to book with you, what's the number one way you can help them get started?
I think it's to really help identify what is it, how do you do it, and why does it matter? Right? I mean, I think, look, telehealth is here to stay. It's not going away anytime soon. And so I've had practitioners, providers say to me, I've had two groups of providers. One group says to me, you know what? I love this telehealth. It will be a permanent part of my practice from here on out. I've had another set of providers, practitioners say to me, I can't wait to get rid of I can't wait for COVID to disappear and get rid of telehealth, and I can go back to face-to-face appointments with my patients. The difference between these, and interesting thing is, I've never heard anybody in the middle. No one has ever said anything in the middle. It's either one or the other. And I think the reason for that is the ones that say, I love this telehealth, it will be part of my practice forever, started with a well-developed plan. The ones that say, I can't wait to get rid of this, did not have a well-developed plan and have run into problems and potholes. We know where the potholes are. If you can avoid the potholes up front, it's going to run that much smoother. And I'll leave one other thing. I think patients are expecting a different type of experience virtually than they expect in person. And the main thing that patients are looking for virtually is that their problem is solved with one call, one visit, one virtual visit. But what they're really looking for is for their provider to convey empathy virtually. And I think that's an area that providers have not thought about. And it's an unknown, right? And sometimes it's a known unknown, sometimes it's an unknown unknown. But that's what patients are looking for their provider to display empathy virtually. And that's an acquired skill. And I do believe that the clinician of tomorrow will have an ever increasing digital component to their practice. So clinicians of tomorrow will have more digital skills than the clinician of today. And that needs to grow as a provider.
Yeah, yeah. No, and it will. I mean, it has to. It's the sign of the times. I mean, it's where, like you said, it's here to stay, and it's where everything is going. Um, yeah. No, that makes sense. That's good. Um, wow. Okay. Well, yeah. That's good. I like it. So if you need help building your plan and you're ready to use technology to improve your service without necessarily AI, please book an appointment with Erkan here and on Telehealth today when we open, or reach out to him independently. But yeah, no, it's good advice. Make your plan, know your intention, define it, and therefore you'll be able to grow with it. So thank you.
What is it? What does it do? Why does it matter?
Yeah, 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 yeah. That's good. Yeah, no, and I like what you said about empathy too, because even in 90% of business, active listening is such a powerful skill, and it's what your client wants, and the health is no different. So I think that's very true and good as well. Yeah, all right. So thank you all for being here. Thank you all for watching. Anyone watching the replay, you can book Erkan and anyone else on telehealthtoday.net November 1st. Lots of exciting things happening. Until next week, have a great week. Thank you, Mr.
Thank
Erkan.
you, James. Thank
Bye.
you.
Yes, sir.